Hi everybody, Dr. Richard Stevenson here, and I'm the Director of Stevenson Dental Solutions in San Dimas, California. And we're a teaching center with a focus on hands-on courses to improve your skills and knowledge. Today we're going to cover the ceramic onlay part 2, the preparation. You recall in the previous video we did the clean out. So let's get started with this preparation. You can see that the tooth has significant issues, a crack on the distal, fairly wide isthmus in some areas, and these class 6 erosive areas. So we're going to go ahead and start the prep with the burr 847KR016. I like this burr a lot because it is 1.1 millimeter wide at the tip and 1.6 at the widest part of the diamond area. And you can use this for a lot of different preparations. It's one of the burrs in the SDS burr kit. We're doing the C-plane reduction, in other words, a non-functional cusp. We'd like to have this about 1.5. Sometimes the prep could be reduced only maybe a millimeter if the function allows that, but you're going to have a little less room for anatomical design. You know, the grooves can't be quite as deep, and it's going to be a little bit less strong than 1.5. You could go 2 millimeters as well. It's going to be quite thick, but it'll give you a lot of opportunity to create some beautiful anatomical grooves. This is the 1.5 RGS showing you that we're not reduced quite enough. So we're going to go back at it again with a little bit more reduction on that C plane. I like to start on the C plane. That's the aesthetic plane on this tooth. It's the reduction that is going to really matter in terms of how we're going to manage that facial cusp reduction to make it look nice. This is the RGS4, which is 1.5 wide. That's just another way to check your reduction. So it looked pretty good, but if we look at it from the facial view, it's under-reduced. So we've got to tip the burr just a little bit flatter to get the reduction in that area that we want. One of the things we can do when we're deciding how to angle the burr is to parallel the cusp inclines. That's usually a pretty good idea. And don't make it flat like this, but follow that angle. And that same angle will be used for the functional cusp, and then we're going to show you the technique where the B-plane will be established so that we know that we have enough occlusal clearance. It's a pretty cool trick, and we'll show that coming up in just a few minutes. But the A-plane is typically going to be parallel to the C-plane. So at this point, let's just continue with the C-plane, the facial cusp reduction, and rise up the triangular ridge to the crest, and then lower the burr down on the mesial side. So you're trying to mimic the morphology of the cusp, and this will make a difference because when you go to cement your ceramic restoration, it will follow the flow of the cusp, and it tends to make it look a little bit nicer rather than have it go straight across. Of course, some clinical situations won't allow you to do this because you have defects or caries or things like that, but when you have a choice, it's always nice to do. We really don't have to take the burr quite this far towards the adjacent tooth because we are going to drop a box back here. But in this case, there is a space between the teeth which we are going to correct, and that's going to require a modification to the proximal box on the distal. It's going to be wider than it normally would be so that we can get proper contours to close that space. Now you can see the C-plane as it's finished, and the angulation here on the C-plane will be used to create the A-plane. C-plane, A-plane, or functional cusp bevel. So let's go ahead and use the same technique where we're going to be cutting down and using the thickest part of that diamond to tell us how far we need to cut into the tooth, and then we're going to shave the adjacent areas to match that initial cut. Essentially, it is a depth groove, but it's more like a depth plane, isn't it? Because we're not making a bunch of little depth grooves that we connect together. And I think that if you've been watching some of my other videos, you know I don't really like doing that because it tends to leave a lot of little grooves between these reductions that are hard to remove. And just another view, and I'm speeding up the video, showing us reduce that mesial lingual cusp. You can also look at that class 6 erosion area and watch it disappear, and that's also a good judge of how much to reduce, because you know you need to go way past that in order to have the proper reduction. The RGS-4, once again, to verify that we're producing okay. And this can be used intraorally. I use these all the time. And it's surprising how many times I'm under-producing. Look at the marginal ridge of the adjacent tooth. This could be a really great clue as to where you need to produce. So one of my lab technicians told me one of the first things we look at with crown preparations or onlay preparations, we look at the adjacent marginal ridges and see if the doctor reduced enough, and it's surprising how much of the time we underproduce in those marginal ridge areas. You can see at this point that the A plane looks to be completed. Now we're going to create the B plane. And the objective with the B plane is to reduce the appropriate amount, do it at the right angle, and the way to find out that you've done it right is to line up your prep cusp tip where the adjacent unprepared cusp tips are. So I'm just marking this here to show you our goal is to reduce the B plane such that the lower ink mark will represent the cusp tip of our preparation. And this is a great way to verify that you've got adequate clearance. This is one of the planes that's very difficult to measure intraorally, and it's oftentimes an area of under-reduction. So let's just go ahead and utilize this trick to reduce the proper amount. And you see how the black mark there on the mesiolingual cusp is now the height of that cusp. It's a terrific technique, and it's just about foolproof as long as you've done the C plane and the A plane correctly. So our distal box extensions are going to be quite a bit wider in this case because we do want to have adequate space to create the contours. I'm going to use a KS0. This is a great burr because it's round-ended. It's narrow enough so you can easily place it between the teeth. It's only 1 millimeter wide. So go ahead and drop this burr interproximally. Keep it away from the adjacent tooth. Even if there wasn't a space, this burr would work quite well. You can go a little bit more axially to avoid hitting the adjacent tooth. And much like an amalgam or a composite, you're going to create these undermined little lips on the buccal and lingual walls, which you can knock off with a hand instrument. Now it looks like, oh, that's great, we're done with the box. No, we're not even close, because we need to make that box wider so that we can have adequate contour and not just a little bulge to close the space between the teeth. So we want to be conservative, but at the same time we want to try to mitigate this open contact problem that perhaps the patient was complaining about. So that requires a wider box. The burr is not tapered, so you are going to need to tip the burr buccally and lingually. And also mesially in this case to create the axial wall occlusal convergency, and the same thing on the mesial. So we're looking a little bit better now, but it still needs to be refined. This is a nice burr to remove little undermined lips. It's the 8850-012. You've seen me use this burr in other videos. And what I like to use this for is removing those little lips, those little C shapes out on the edges there, those little bird beaks there. And it's so small, it's easy to get in here and use this burr on all 4 of those walls. Pretty simple. So at this point, let's go ahead and create the shoulder on the functional cusps, and we're going to utilize the burr we've used since the very beginning, which is the 847-016, and just use the bottom portion of the A plane as your guide and just flatten that wall out a little bit. There is another technique called the V prep where you don't actually create this functional cusp bevel. I think that preparation design is inherently flawed. We've performed a study at UCLA looking at that design for strength, and one of my students obtained her master's degree writing a thesis on a laboratory study looking at the strength of onlays with the V prep versus this prep. I think that if you use 8881, 012, 1.2 millimeters in the slow speed and the high speed, you can really make things nice and smooth. And these little transitions, see right there, you don't want to leave that sharp edge. That just creates a real problem for the technicians. So we want to round those little corners, and this is what really kind of takes the time with an onlay, is all these little details. We really have to fuss with this and make the preparation finish line as continuous and smooth as possible. Everything on the outside should flow. No sharp edges should be in place anywhere on the outline form nor on the internal form. So let's round those areas off. It's a little bit tricky, but with some practice you can get quite good at this. I'm just speeding up this section to show you how we would use this burr to round off all sharp edges between the axiopulpal area and also all those vertical wall areas where the isthmus meets the B-plane and C-plane. I think slow speed or electric handpiece is ideal. When I'm using an electric handpiece, I'll slow it down to 500 or 1000 at times, and I'll use the microscope or at least very high magnification to make the corrections. I would say that this part of the procedure is the longest step. It takes quite a lot of time and focus and discipline to look at every little detail and try to improve them as best you can. So when you're finished, you have a pretty nice flowing outline form, and I think that it's worth the extra time to do this. This is at RGS3 showing you that the boxes are a little more than a millimeter deep axially, and that's great. That's plenty thickness and about a 1 millimeter shoulder on lingual. Single C-plane, which is going to create this butt joint out on the facial. Round everything off. It takes effort, but it is so important. Take a look at this from the facial. You can see it replicates the cusp shapes, and then the transition there on the distal facial is very smooth between the box and the occlusal reduction. So here's the final prep, far from perfect, but I think it's going to work for us. In our next video, we are going to prepare the MO inlay on tooth number 2 adjacent to this onlay, take a final impression, and send it to the lab.
Once I come to this webinar organized by ADPA, I'm taking over on the behalf of ADPA team because today's topic is such that it's a very vast topic, and ceramic restorations as such is such vast topic, and we tried to divide this into two anterior, but again, topic is such wide, so I thought I'll play this video for you so that you'll have a mindset before you get into this webinar. And before I start, I would request you to take a pen and paper so that you can jot down things and tips and tricks and materials needed and whatnot. So many things to be covered in this webinar. I'm sure it will be such a wonderful session for you all. And if colleagues have not joined yet, I'll take a minute and just ping them, message or give them a call to join, because I'm sure they are gonna miss very much informative session. And now I'll just share the screen so that we'll start immediately now. Yes, my screen is visible. Can you just type it in the chat so that I get to audio? Am I audible? Yes. 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 Perfect. Yeah. So on the onset, again, I'd like to congratulate EPA team for and a word of appreciation for them for arranging such a webinar on important topic in our daily dentistry. I'm glad that chosen one for this. So, and I'm sharing as much as possible and giving back to dentistry whatever I have learned, because it was a very hard time. I had started my dentistry and practice and reached to this level where I'm sharing my experiences and knowledge with you all. Okay, so let's start the session. Today's topic is ceramic restorations on posterior teeth. And last week's session was such a wonderful one. It was overwhelming response from the participants. We had around 100 plus participants last week. Just a brief for the participants who are newly joined. I'm Dr. Sufiyan Kalekhan. I am a prosthodontist and I'm practicing in Kuwait. I'm ExoCAD and ExoPlan trainer. I'm faculty at Cochin Implant Center. Dr. Jamin, if you have been know, I'm a member of Royal College of Surgeons, Ireland. Integrated implantology course I have done from Germany, and Ministry of Health license holder. So why I'm showing this in every slide, because I want you to focus and step each year and gain something new in your profession. And so that you can keep in touch with the subject. And dentistry is growing such running fast, and we are growing such in a rapid speed. I want you to get into that and catch the train. I don't want you to miss the train. And this is my lovely wife. She's also a prosthodontist and implantologist. We work together in two different centers. Whenever the collaboration is needed for cases, yes, we get into one center and oppose the case, the clinic. Word of appreciation for my staff, without whom my practice would be not possible, right? So today's topic, ceramic restorations in posteriors. Okay, so last week we explored this application in anterior teeth, focusing on aesthetics and precision. So just share with me how's the experience was with the ceramic restorations. Has your practice improved, or did you change a little bit after last week's webinar? Right? Just type it in the chat box so that I can know how I have made a difference for that. So today we'll shift gears to discuss ceramic restorations in posterior teeth, where strength, function, and longevity take the center stage. So let's dive into the crucial aspect of this restorative dentistry, right? So you guys started doing the, I got a message in the chat, voice is not clear. Is it fine now or is the same? So what difference you have done in practice? Yes, go on writing in the chat. I'll read it out in the course of the webinar. Yes. So what are the situations we see in our day-to-day practice? Cavity preparation, cavities, where we give inlays, onlays, overlays, and also patient will have the aesthetic demands, and not to forget the restoration should last long. If not, the patient will come back say restoration is failed. So large cavities and root canal tooth. Why is it so important that we restore this, with the function? So remaining tooth structure is important to consider, not directly jumping into the cavity preparation and giving a crown, or post-endo filling, doing that, right? And not to forget the aesthetics, because the patients with wide smile line will have some difference in the shade, where the patient will try to complain regarding this, and moreover you will not like the outcome of that. When you are going to inlays, onlays, and overlays, again the shade matching is very important. Selecting the material and the type of the shade for the material. In the course of webinar I will tell you. And the patient is having any parafunction habits, you need to consider, because we are dealing with the posterior teeth, right? So what are the options we have? direct restorations or indirect restorations situation. Keeping the durability, aesthetics, time, and cost, we can go ahead with the, if the cavities of fractured root canal treated tooth is there, composite fillings will be done, and then the direct restorations is done. If the cavities are quite not deep, moderate cavities. What are the advantages of this composite restorations which you do? That is a in direct restoration. Same appointment treatment can be done. Preservation of structure, satisfactory durability, and technique is easy of placement of the composite restoration. The disadvantages, if I can think of, is discoloration, fracture resistance is less, color matching when compared to aesthetics is not that great. Again, the disadvantages of this direct restorations, as last week, are the indications for indirect restorations, keeping the function and aesthetics in our mind, right? Function and aesthetics. This is very important. So, ceramic restorations in posterior is our webinar for today. Again, once more, I'm highlighting superior aesthetics. It doesn't mean that you are doing the posterior. Aesthetics is not going to play a very important role. I'll just go ahead if at all there is some issue. Just send me on the chat. I'm just looking at the chat right now. It will just here so that I can correct it. Yes, replacing the old composite, amalgam restorations or any glass ionomer restorations. Discolored tooth, which can be given the ceramic crown inlay onlay. Old restorations, old crowns where they are fractured. Full rehabilitations where replace the old amalgam restorations and the anteriors with the veneers and crowns. Again, the posterior restorations in the full mouth cases with the bite rise also, raising the bite, raising the vertical dimension, or the patient who has come for anterior restorations, maybe they are not aware that the crown color in the posterior is not good, or they have open margins. You suggest them to change the posterior the ceramic ones so that the aesthetics will improve and the smile also will be enhanced, right? Again, replacing old crowns in the full mouth cases. Aesthetics, right? Not just in anterior and in the posterior as well. Imagine you are laughing like this, or patient is having a good smile in a meeting or having a great time with the family and friends, and the patient sees the restorations like so. Suggest them, show them this photograph, suggest them this is what the upper person will looking at. Don't you want to change these restorations for ceramic ones and a tooth color? So you're not doing anything wrong by suggesting them. You are just guiding them because patient doesn't know that these can be replaced also. Amalgam was a only option for them back 10 years or 15 years where the ceramic was not introduced and was not popular, right? So incorporating science with artistic abilities is what we are looking at with the ceramic restorations. Aesthetic dentistry has evolved so much when compared to past in terms of new materials, new bonding protocols, new cements, and newer techniques. I'll be discussing all this in the course of my talk. From the start to finish, I'll be discussing this each step. Just like I said last week, I'll just brush up. Material selection has to be done before even the tooth preparation is started, right? The lithium disilicate, I'll see lithium disilicate since the topic is ceramic restorations. Again, lithium disilicate can be a multi-restoration or a restoration. And the mono is the whole block is in single material and there is no layering on the top. The same example which I give chocolate and cake where whole chocolate and ganache is like a layer on the monolith. Multi-layered comes with different layers here, opaque, tinted shade, enamel shade, and on that glaze. So lithium disilicate can either be used as monolith, layered, or back design. What are the advantages of this? Aesthetics is good, flexural strength is excellent. And after bonding, as I said last week, the bond mechanical properties increases exponentially. It is good with the soft tissue, that is biocompatibility, and the CAD/CAM technology application allows us to have a precise restoration. Drawbacks, what only drawback which I can think of is technical, because there are so many materials or the techniques you need to follow during the course of the restoration. In all areas, anterior and posterior inlays, onlays, overlays, and tail can use the ceramic restoration. Contraindication is only long that ceramic is not that great. So again, this is all the repetition of what I have spoke last week. So just so that there are so many things to cover, and most importantly, we are speaking on posterior, and I cannot miss to miss occlusion. Discussion half of the webinar is on the occlusion. Many issues. And we started doing ceramic in the, and after few months back in the hand, and you said ceramic relations are so well. I do in this through the occlusion also, right? So monolithic and multi-layered heat pressing, milling CAD/CAM, CAD/CAM milling. It can be done in CAD blocks or in the press blocks. Pressing, again, it's with the sprue former. You will do the investment, burn out, and then you will press the ceramic material to take the shape of the wax up which you have done. Again, lithium disilicate can be used in inlays, onlays, or crowns, or tabletop restorations, as seen like this in the picture here. These are the crowns. It can be fabricated with the CAD/CAM technology. Veneer lays, onlays like these. Am I audible now? I'm very sorry for this. Any point of time, if I'm not audible, I'll just repeat the slides. If just let me know. You can see this photograph, this table on the screen right now. This is an important one. Every restoration, ceramic can be done. Veneers, occlusal veneers, overlays, very thin veneers with 0.3 millimeter, anterior bridge, posterior bridge, but not exceeding 4 units. Again, the same protocol. You will do a diagnostic wax up after making the primary impression, whichever tooth you are preparing, maybe a single tooth preparation or a full mouth preparation. You can do it by manual wax up or a digital wax up. With the digital, again, you need to print a 3D model. And why should you do a diagnostic wax up? As I told last week, pre-visualization to evaluate the teeth size and shape, assessment of the occlusion, which is very important now, and to communicate with the lab technician. So again, the laboratory's responsibility is to establish. Is it? Just a minute, I'll just change my connection so that give me a second. Yes, so I have changed the connection. Let's see, hope this connection is secure and working well. Hmm. Okay. No. Yes. So let's continue. Lab instructions is very important. It should not be very arbitrarily done based on the technician's interpretation of minimal clinical information, because technician doesn't know what kind of posterior restorations is the reason behind you giving a posterior restoration. Maybe the patient has come to you with two appointments where the composite inlay has broken or onlay has broken twice, and now you have decided to change it to ceramic, and the lab technician doesn't know the reason behind it and he doesn't care about the occlusion, and you do this ceramic restoration and again it breaks, right? So you need to instruct the lab technician what you want exactly, and it should be a case related. It should not be a very generalized one. For every patient you need to write a lab order book, right? So this is the wax up. Again, we will do an index, full mouth, or a sectional index based on whichever the tooth you are preparing. Again, to remind you, lithium disilicate is a versatile material where it can be monolith, layered, or a cutback technique. So jumping directly into the preparation, you have seen this video in the start of the webinar, how the preparation was done. Okay, that is for the onlay, and this is for the crown, which I'm sharing right now. Just remember, functional cusp functional cusp reduction has to be more, and the non-functional cusp reduction should be less. Okay, always remember this, because functional cusp reduction is more, the ceramic material will be more, and then the occlusal forces can be easily withheld by the ceramic. Okay, do not forget this. Rest all very minimum preparation, 0.5 to 0.8 preparation is just enough for the ceramic crown, right? This is for the zirconia coping and a ceramic layer on the top. Again, the functional cusp bevel should be more, that is 1.5 to 2 to compensate for that multi-layered restoration. Okay, this is just this is a chart to summarize the tooth preparation in the inlay. You can take a photograph of this and take a printout and stick it behind you. I mean, just beside you during the patient, right? Just to have a quick look. Posterior crowns. Unless I do it and show it to you, I cannot explain you the preparation, how it is different in the occlusion or in the buccal or a lingual. That's the reason I showed you the video, so that you can correlate the preparations, the preparation design which has to be done. Okay, this is for the posterior bridges. You can take a photograph of this or take a screenshot, right? So that's a crown preparation or a complete coverage preparations. And now comes the finish line. As I said last week, modified shoulder and deep chamfer is the only finish line you will remember. Okay. Again, the modified shoulder, that is also called as rounded shoulder, as a tapered round. See the shape of the burr. Did you check the burr which you are using after last week's webinar? Which kind of burr you are using or which kind of finish line, right? Did you check, or did you change your burrs since the last week? So that's the modified shoulder where the 90 degrees angle will be there externally, but the internal line angle is rounded, but the chamfer has a sloping margin. So tooth preparation finish line, make sure your burr is not tilted more. You should have a tapered preparation at the end. So keep the burr as straight as possible, and half of the burr should always be inside the preparation and half should be outside. Do not sink completely the burr into the tooth, right? Because you are using a deep chamfer burr and the edge here is So see this, this is the rounded edge. So if you use use it completely inside, your preparation also will be like this. So only use half of the burr and half should be outside. So tooth preparation, modified shoulder only for PFM, the rest all deep chamfer. Finish line is only finish line you will remember. Accordingly, you will order your burrs. So again, to revise, green or blue for the gross preparations, red for the finishing, yellow for the polish. Whole set you need to keep in your practice. So these are the different grids in the magnified section: green or blue, red and yellow. Do not use the burrs unless they are fresh burrs. Use, maybe you're preparing 4 or 5 preparations on a single patient. You throw the burr. Do not use it back again. Maybe 3 or 4 times is the maximum which you can use a burr. Rest all you are creating heat on the tooth surface. And mind you, you are doing the inlay preparations where the tooth is vital. You cannot afford to hurt the pulp, right? That will cause a post sensitivity. This is one of the reason where the post op sensitivity for the patient is there. That will annoy the patient. Patient will come back to you. Then again, you will be annoyed saying the ceramic restorations are not good. Inlays, onlays with the ceramics are not good. Let me stick to the composite, right? That's how the mindset goes on. So make sure your burrs are regularly changed. Keep a separate burr kit for that. Posterior burrs are a little shorter. And as I said last week, stop at red when luting the crown. That is for the zirconia based or a metal based restoration. You will stop at the red burr. For the ceramic preparations, restorations, you will use yellow. And again, after this, you will use a super polished discs also. Okay, so for all the ceramic restorations, you'll use green, red, and then yellow also to polish the surface, because the ceramic restorations are bonded, not luted, right? So next part of the lecture is something very important, as I divided last time in the anterior, biomimetic dentistry in the posterior. Okay, this is very exciting now. So in biomimetic dentistry, you will preserve the tooth structure. That is less preparation, which is maximizing the adhesion of the restoration to the tooth structure, restoring the structural integrity, and using the biomimetic materials and techniques, that is the ceramic material. So again, we have reached to 0.5 or 0.1 minimum preparation, giving the ceramic restorations. Again, to repeat, finish lines are very important. Which finish line do you prefer? For the ceramic, deep chamfer only. Modified shoulder, if the decay or the old restoration is deep, you will convert that into a modified shoulder. If not, if it's a fresh tooth preparation, only deep chamfer, right? Again, see the burr design. Start using loops. Hold your burr and check the shape of the burr through the loops. You will appreciate how the shape, how the end of the cutting end of the burr is there. Okay. So you'll have this kind of a chart for every burr company. Ask them to send it to you. This has codes here: RS11 or RS21, RS31, TR. So what is the full form of this RS? RS is nothing but rounded shoulder or a modified shoulder. TR is nothing but tapered round or deep chamfer. So if you order a RS burr and try to give a deep chamfer, it will not happen. You get my point? So to get a deep chamfer, you have to order tapered round burrs only. So make sure you look into the catalog of the burr, go online or ask your dental material provider to send you the catalog. Look at this and then you order the burrs, right? As I said, keep half of the burr outside. Do not sink completely into the preparation tooth. Why? When we sink completely the burr inside the tooth, you see this extra preparation because this is a deep chamfer burr which has a rounded margin, rounded cutting edge. The same cutting edge will be replicated on the tooth, and this will be recorded in your impression, and this will be converted into a cast. Do you think this extra margin here will be present in the cast? This extra margin here? No, this doesn't have any support, and on the cast this will not be there. It will not be seen by the lab technician as well. The lab technician will fabricate a crown according to the cast which he has poured, and then he will fabricate a crown, and you will do a try-in. You will find an open margin like this, or the crown is not fitting completely in the tooth on the patient's mouth. And you have promised, Mr. Patient, next appointment will be your last appointment, because I'll be cementing your crown or a bridge. And you also advise him to do a complete payment beforehand to just make sure you will get a you will not have any balances later, and you will have to face this situation. Who is at the fault here? We immediately call the lab technician and give him a word saying your work is not good, right? But what has happened? It was us who did this mistake, right? So always in every step, make sure you are very sure of whatever you are doing, right? So again, do not sink completely inside the burr. Once the cast is ready, tell the lab technician to send you the cast, put on your loops, and have a look at the margins. Your margin should be visible like this to you on the cast, right? On the cast, the margin should be visible. If the margins are not visible, something like this, you cannot create your own margin. You have to make a new impression. You might ask me, Dr. Sufiyan, I have to make complete set of impressions again. It means the temporary I have to remove. I have to use a putty light body, new impression, place back the temporary, one more appointment, one more hour of work. Yes, you have to. There is no shortcut for this. That's the reason after the impression, have a look at the impression very clearly, and the margin has to be visible there. So how the tooth preps? The toothbrush which we have seen now was for the crown, right? We'll just see how the tooth preparation designed for the posterior teeth for veneers, overlays, onlays, inlays. So in the premolars, that is the kind of preparation you do. You will just remove the facial aspect for the veneer, because veneer is only an aesthetic demand of the patient unless there is any decay where you will extend little deeper. You will not break the contact also because there is no need. Patient is not, when the patient smiles, the contact area is not seen at all. So we'll stop it just before the preparation. The contact point, contact area. Only the facial aspect has to be prepared. See, this is the premolar preparation. Supragingival finish line or equi is what we are looking at. This is the lower preparation where I had to involve this composite restoration and get an enamel ring on the top so that I get a good bonding surface for the ceramic. Okay, that's how you can break the contacts and then go deep, involve this composite, and beyond this, you'll go and prepare the tooth. That's how it look clinically, where the amalgam restoration is there. If you're not ready to, and there is no micro leakage, the amalgam is intact, composite is intact, no need to replace it. Just cover everything below the preparation and end the finish line here. There is a decay, so I went more deep, breaking the contact, and always use retraction cords or retraction paste. That's the posterior preparations. So coming to the molar tabletop preparations, onlay, inlay, and overlays. Why are we giving the preparation, the ceramic restorations in the molars for the aesthetic demand? You have a patient with a case of bite rise, that is vertical height increase, replacing old ceramic restoration, old restorations of amalgam or composite, and the patient is having any occlusal wear facets or post root canal treatment, you can give in onlays or overlays instead of crown. Yes, I'll tell you how. So what is the idea behind giving a root crown, full coverage crown on the root canal treated tooth? Why do we crown the root canal treated tooth? First of all, because after the root canal, there is no blood supply, there is no nerve supply, nor the hydration. There is no water content inside. There is no the pulp is removed. So that's where the nutrition is getting for the tooth. So once you remove, the tooth starts becoming brittle. To cover this, you will give a crown. But imagine you have a uh, caries from the occlusal surface. There is no involvement of the distal or distal or a mesial marginal ridge. It's just a occlusal deep caries, and you have done a root canal treatment. Do you think you need to reduce whole of the tooth structure just to cover the occlusal surface? No, you have to cover only the post-endo restoration area because there might be micro leakage from the composite or the tooth is getting brittle, right? So you might as well cover only the occlusal area in such situations and give this overlay. Only thing which I am looking at is 1 millimeter of enamel ring throughout. See this 1 millimeter of enamel ring at least throughout. I'm not breaking the contact area also, and making space and occlusally to give a good ceramic overlay on the top. You see this? So that's the overlay. So coming to this onlay preparation now, your onlay preparation is little more deeper. Or what's the difference between overlay and onlay? Onlay, you would replace one or more cusps of the tooth. Onlay can be involving a cusp or just involving only half of the cusp or only one cusp only. Okay, or completely all the cusp. It will be converted into an onlay. And when preparing the onlay, you are not supposed to prepare it straight like this, where prepare like this. No, because the distance between this and the pulp horn is very near here. You will follow the tooth anatomy on the occlusal surface. So around 1.5 to 2 millimeter occlusal surface you will reduce for the onlay. There are special burrs. Depth marking burrs are there, 1.5 millimeters or 1 millimeter. There will be a black marking, or you mark with the marker, and then you can use this regular your burr as a depth marking burr. Angulate this. So as I said again, unless I show it to you practically, I'll not be able to explain it to very well. That's the reason the video was shown. Just imagine this kind of situation where you are doing this preparation with these burrs. These are the special burrs where the occlusal preparation can be done very easily. And the same finishing burr as well. Same width, same dimensions, length and width of this has to be taken. If you want to convert this onlay into an overlay like this, again, you can involve this palatal surface or a buccal surface to give an extra retention. That's the case. Old composite restoration removed. This is the arrested caries. I put a layer of opaque composite to mask this discoloration, make the impression, send it to lab, get an onlay, and then cement. There's a molar. So that was a preparation where buccal or a palatal tooth has to be prepared. So these are the tabletop restorations. These are tabletop restorations where only the occlusal surface has to be prepared, not the buccal nor the palatal. Where are these kind of situations we come across? Where we need to raise the bite in a full mouth cases, or the patient is having a occlusal wear facet. There is already the tooth structure loss and you don't want to prepare more on the occlusal surface. You can give this kind of a tabletop restoration, getting just a shape of the tooth and make the impression, send it to lab, get the ceramic restoration. If it is not in the smile line, so you can bypass the shade selection very critically. So few times, as you said in the saw in the last case, there might be areas where the dentin is very close to the pulp, and this might cause post-op sensitivity. In such situation, you can do something called as immediate dentin sealing. This is very important because you are removing the fresh dentin. It means it's a source of irritation for the tooth, and that will cause sensitivity post-operatively, right? So you can do this immediate dentin sealant, that is applying a bonding agent or a dentin sensitivity agent on this floor of the tooth prepared, and then using a flowable composite, making it flat. But on the enamel, there is no flowable because you want this enamel surface for the bonding of your restoration. It should be only in the dentin area. Sages temporary restoration here. Patient has left it over the years, took out the temporary, saw this old composite. I did not involve this. I have a good enamel ring. Preparation is like this. That's the impression and the cast. Onlay or overlay, whatever you want to call it. Ceramic based. Then cementation was done. Okay. Do not have the photograph of that. So this is a crown lay. Imagine now you have this post-endo filling composite here. These days you were preparing whole of the crown. Why? Why are you involving this lingual surface? Why are you involving this buccal surface, giving a retentive groove extra? Why? You are losing the tooth structure, and again you are giving back a new crown on top, which has a new surface. So you might as well don't prepare this lingual surface, just prepare the proximal and the buccal and the occlusal. Allow this thick enamel band to be preserved during the preparation. You are going this deep because this is the access opening, which is very deep here. So your crown or onlay has to be covered by the restoration here. This is again post and post core case. This is the post. Just involve the buccal and the proximal palatal surface. No need to involve. You have this enamel for your bonding. Again, smile designing cases, if you are extending the veneers from the anterior to the posteriors, you can give this veneer lace where very thin preparations can be done. Again, cementation has to be done with the rubber dam. So now these are the crowns which you used to do. So are you thinking right now you are doing too much of crown preparation instead of giving the overlays and onlays, right? Again, if you want to go ahead with the crowns, you can prepare very minimum tooth preparation can be done. Only 1 millimeter or 0.8 millimeters, and you can give a full coverage restoration, give an extra retentive groove. If the restoration is deep, your idea is to get enamel ring, no matter how deep it goes. Go deep into the gingival sulcus. Do not do any gingivectomies. Save this keratinized gingiva. This will help the patient in, there will be no food lodgement in the future. Okay, this interdental gum is very important, very important. So tell the patient, Mr. Patient, I will be giving you a long-term temporaries because your situation is like this. I have to go deep and get the enamel at the bottom. I'll give you a temporaries. I'll call you back after 3 weeks so that the healing is done. Remove the temporaries. See such lovely gingival cuff here. make the impression, send back to the technician, and cement the restoration here. Full coverage crown. Ceramic loves gingiva. There will be no harm. You are preserving interdental caul area here, keratinized, which is protective. You are giving a full coverage crown. This restoration is a success and it will last long. See this comparison of crown and overlay, right? Again, discolored tooth is there. Go ahead with a full coverage restoration. Give a opaque layer inside. Tell the lab technician send this photograph and tell that the opaque layer you have to do because the dark restoration is there. And then give a full coverage crown ceramic. Full mouth cases again, very minimum preparation can be done. See this deep restoration. This was done without the root canal. All the debris, decay taken out using a fiber reinforced band here. Use a flowable, make the floor flat, and then make impression and only on the top without the root canal. So your idea is to get enamel ring and cover all the composite areas in the restoration. See this post and core case, remove the old post, do a new core, nice tooth colored, good shape, give long-term temporaries, take it out after 2 or 3 weeks, make the impression, send it to the lab. Again, see this, I'm showing you different kind of cases so that you can relate any of the patients who come. Old composite or old GIC, take it out, take out all the infected dentin, use rubber dam, very important, use rubber dam, isolate the tooth. You don't know, maybe you have a pinpoint exposure here and all the debris goes inside, and you have to do a root canal intentionally now. You have created a root canal patient, right? You don't want this. So use a rubber dam, you'll protect the tooth and the surrounding, right? Do a good preparation. Getting a good enamel ring is what we are looking at. Here you have to go deep because the old restoration is there. Go deep, isolate it. Remove the rubber dam. After doing the rubber dam, already the gingiva is retracted. You have to just place the cord wherever needed. And for all this, before all this, give anesthesia so that patient is not having any pain. That's the cementation appointment. Rubber dam, isolate the tooth, do the trine without the cement or a trine cement. Use a resin cement to cement the restoration. Done. See, that is immediate post-op. That was a pre-op photograph, old composite. This is the intra radiograph. You can see this thin layer of flowable here to protect the pulp. After the cementation, after 2 weeks of recall checkup, this is the situation. In X-ray, there is no excess cement. Restoration is bonded very nicely. Are you all awake? Yes? Let me see in the chat. What can you see here? Type it out. Type it out. What can you see in this photograph here? Tree. Yes. Now, squint a little and close your eye, half close, and then check. Is anyone up noticing a leopard and a gorilla? Close your eyes half. Lion, monkey, yes. Animal, yes. Yes, you're all awake. Good. So what can you notice here? Yes. Few more. If your friends, colleagues are around you, wake them up. Lovebirds, yes. Can see a guy and a female and a female. Is anyone noticing apple, green apple? That's a green apple eaten from the sides. Yes. So it's like a patient goes to one dentist. Dentist says it's root canal treated tooth, and you must do a crown webinar. And the patient comes to you, and you say, Mr. Patient, no need of going sacrificing your tooth, precious enamel, giving a 360-degree preparation. Let me do a overlay or onlay, protect your tooth, and also I'll give you a good restoration with the ceramic. It's just a perspective of each dentist, how you do your practice. Because if something goes wrong in the ceramic repeatedly, you will have the option of doing a crown at the end, right? So I'm not telling just for this reason, go ahead with ceramic. No, that's how you build your practice. So you do not want any problems created later, but you will are doing a good uh, treatment. Show the patient the photograph of a crown preparation and overlay preparation. Tell him, I'm charging you a little extra to save your tooth because I'm using loops. In loops, I can see twice or three times larger, so that I will try to save as much tooth structure as possible, which can go in a long run for you. Right? You're not doing anything wrong. Tell a little bit extra for the ceramic restoration. If the patient agrees, okay, doesn't, well and good, go ahead with the crown only. Okay, let's get back to this. And again, after this, you'll do a tissue management. What is tissue management? So again, we have seen the preparations, soft tissue. We have next impressions, shade selection, temporization, cementation, and occlusion. We are still left with half of the webinar. So soft tissue management, I'll just brush through. This is all the repeat of the last time. Just for the sake of completion, I have included this. Again, without soft tissue, your impressions will be like this. We do not want this, nor the lab technician, nor you repeating the impressions. You will have to do this with the retraction cords or the retraction paste. That's a mechanical retraction. Twisted, braided, and knitted. Knitted is what we are preferring because of the way it is done. There are thousands of strands which is made into one single strand like this. So it will compress when packing, comes in contact with the fluid, it will swell up. That's how the retraction is there. Again, the single cord technique where the thinner cord is used, and it should be completely into the sulcus. It should not be seen. Finish line should be seen, right? When we use a double cord, only then the double cord can be seen outside. This is for the horizontal retraction. See this photograph here. Double cord technique. Thinner cord at the first to get a vertical, and thicker the second for getting a horizontal retraction. TY documentation is important. I did not notice this chunk of calculus on stain here. Once I was doing this video, I could see because the patient has having a very thick cheek. So I made sure I removed this after the retraction. So you guys started documenting, taking photographs, not with a professional camera, at least with the mobile or the chair camera, right? You can do that. Did you start doing the retraction? Did you buy retraction cords? Invest a little on these, charge little more, only just cost to cost for the patient. That's the first cord, and this is green one is the second cord, thicker one. And again, as I said, do not force your cord placement like this. You are hurting the gingiva. Okay. You can use this astringent retraction paste. I'm not promoting this brand, but I'm using this since many years now and it works for me. That's how you put the paste, push the tip little into the sulcus, wait for 2 or 3 minutes, wash it, not with too much of pressure because the clot might dislodge. Okay. So then you will do the impressions. Again, impressions has to be done in two stage. First stage impression with putty and then second with the light body. Your light body should cover the preparation margin. You can use these barrier strips, barrier sheets to get a first stage impression. See, that's the impression of a inlay. Your inlay cavity has to be covered with light body, not your putty. Putty will not go inside. So fill it up with light body as much possible. See this, appreciate this two margin. This margin is a finish line. This margin is the sulcus. And posteriors, mind you, don't need to give subgingival finish lines. Supragingival or equigingival is well and good. See this? I'm sorry for the screen. I don't know. There is some issue here. See these margins here. This is how you have to be. You have to see these margins and then send it to the lab. This is a preparation of the. This is an impression of the preparation which you saw few slides back. The premolar finish line is seen very nicely. That is recorded. This is a case of a MOD onlay. But why I'm telling you to zoom, take a photograph and zoom or use a loops. You see this air bubble here. This will cause a issue later, right? You see this air bubble here. This will cause an issue. I do not want this. I will repeat my impression after this, right? Again, margins, appreciate the margins. If the cavities are deep, make sure you examine the impression immediately. See this? This is a void created which you do not want. It will be again converted into a cast like this and the restoration will not fit. Two-stage impression is what we recommend and is to be done, not the single stage like this in the top. Again, stabilize your trays. Do not ask the patient to bite. Bite registration with polyvinyl siloxane, PVS material, that is addition silicone based bite registration material, not the modeling wax. There is a preparation. The video of a scanning. So this digital dentistry, again, you need to examine after your scanning also. Scanning doesn't mean the precision. You have to make sure retraction is done and then you do the scanning. Again, you select the shade. Stump shade is very important, right? Discoloration here, grayish or blackish, has to be told to the lab technician. Stump shade selection has to be done with dye material shade guide or a composite shade guide where you can find these darker shade tabs. Again, you will temporize it with the index which you have taken, or wax up which you have done, temperize it with the base acryl material. Why temperization is very important? Many of you might be sending back the patient after the tooth preparation without giving temporaries, right? No, temporaries are very important to allow tooth not to supraerupt or migrate mesially or distally. And to prevent this, temporary has to be done. And also post-endo filling might break if you do not give temporary tooth. Okay, temporary is must for any inlay, onlay, or any anterior or posterior restoration. Recall the patient, remove the temporary. See the lovely gingiva here. It is erythematous, yes, but it is not bleeding. Unless it is not bleeding, I am fine with it. So always after the temporaries, polish the temporaries so that the gum is not inflamed once you call back for the cementation protocol. Temporization has to be done with the Luxatemp, Protemp or Telio. I mean, this is the bisacryl PMMA material. Any company you can use. This is a smile designing case. Again, the same video which comprises of anterior and posterior restoration. I'll just skip a little so that I can cover the most important occlusion for you all. Again, the 3D model has to be printed, and on top the ceramic is restoration is done. Okay, so this is a little extra cost, but the precision is very high. You can be very much sure of this technique. See this case, old amalgam restoration. I showed the photograph, took the photograph, asked the patient, see this has done around 15 years back. Do you mind changing it? Why? See this crack here and there is colored. Maybe one fine day it will break and you will have to face sensitivity issues. Imagine you're on a dinner with your friend or a date and this happens. Okay, so that's how I convince the patient. That's one of the techniques. I'm not doing anything wrong. I'm just guiding the patient in a right way. So preparation is done here. Enamel ring is there. No crown preparation, only overlay preparation here. Scanning is done. Milling and then cementation. See, this cemented area is nicely seen. There is no overhanging restoration here, nor the extra cement in the sulcus. So after the cementation of any restoration, please take a bite-wing radiograph or take a IOPA at least to see whether the cement is remaining in the sulcus here. So lab communication, again, you have to be done very precisely. Which kind of material? Is it coping or is it a monolith and layer or a layering technique? That's the lab. We have an in-house lab where we are milling the restorations. Always after the removing the temporaries, you have to polish the temporaries. And again, as I repeated last time, prepping the ceramic crown or veneer and preparing the tooth surface. There are two things you have to do. Prepping the veneer, use an IO clean after the trine, and then use a silane agent, etchant, and then a silane agent. That's a table where which shows lithium disilicate and zirconia or any resin material, how the surface treatment has to be done. So again, we have two techniques, two-step technique where you use IO clean, that is IO clean for 20 seconds, use a etchant and a silane agent, or you can directly use IO clean and monobond etchant prime, which has both etchant and a silane agent. And rubber dam isolation is must, be it anterior or a posterior. Exposing the finish line is must. Taking out all the cement is very important. So while cementing, use a oxygen inhibiting layer gel, that is the non non oil based gel. Any non oil based gel you can use. IO Clar company has this liquid strip, or you can buy any readily available. If you are doing a cementation of this ceramic crowns or veneers, make sure isolation is very important. You can use any of these cements, light cure cement. These are light cured cement, not dual cure, light cure cement for the veneers. If the restoration is thick, if the restoration is all the veneers, you can use this light cured, or if you have a combination of this restoration, that is a crown, veneers, or overlays or non-lays in the posterior, you can use the resin-based cement. Do not use GIC, the resin modified glass ionomers or polycarboxylate cements. These are not the these are not the cement of choice for the ceramic materials. Only the adhesive cement, the resin-based cements can be used. So that's the table showing zirconia and lithium disilicate, how the retention, and if the tooth margin, the thickness of this margin ridge which is remaining is less than 2, you have to follow adhesive resin cement, etchant, bonding, and then adhesive resin cement. If the thickness of this remaining crown, the remaining tooth structure is more than 2 millimeters, you can skip etching or bonding. Directly you can use the adhesive cement for cementation. This is very important now. Checking the occlusal corrections with the articulating paper. As I said, always do. Check the occlusal marks before the preparation itself. Okay, do not check the occlusion later after the crown, because you do not know what is the crown type of occlusal scheme your lab technician has given. These are the ideal occlusal points. Other than these are the retentive the occlusal points has to be removed. I'll have to brush up a little more faster to cover all the topic, all the slides. So this is overjet and overbite. This is very important. Overjet and overbite is very important I know you are doing the posterior restorations. I'll tell you why you have to check the overjet and overbite in the anterior in the coming slides now. Why occlusal forces has to be checked very precisely, because after giving the onlay or inlay, you might find the ceramic chip off or cracks on the tooth even in the eventual time, and the patient will complain of sensitivity during the chewing or biting, right? So occlusal corrections has to be done in very precise manner. With what you will check? Articulating paper, you will check the occlusion, and what you will do, you will take the burr and piece and reduce all these marks on the top, right? No, you are not going to do that. So let me just tell you a little more of occlusion, then guide you how to remove the high point. Occlusion is nothing but maximum intercuspation of the upper and lower jaw. As you all know this, ideal occlusion, functional occlusion, on pathologic occlusion. Ideal occlusion is what we are looking for, which is seen in post-orthodontic treatment. Functional occlusion is what the patient is having, and you have to replace back whatever the patient is having. Functional occlusion comes into important when the patient is in the speech, mastication, or during the swallowing. So when I speak of functional occlusion, there are two separate entities which are dependent on each other. That is static and dynamic occlusion. Static occlusion is nothing but open and close. That is a maximum intercuspation. In the anteriors, there should be occlusal marks like this. Why the anterior is very important? Because the anterior teeth are the one which are guiding the posterior teeth. That is a dynamic movement. What is dynamic movement? The protrusive movement when you get your mandible in front, or the lateral movement, that is when you get your mandible in the left and the right lateral movements. That is the eccentric. So anterior guidance is very important. Why? What I mean by anterior guidance? I mean to say the palatal surface of this maxillary anteriors. Imagine this palatal surface of the maxillary anteriors and the labial surface of the incisal edges of the mandibular brushed with each other during the protrusive movements. You can do this now. Get your mandible in front. Which are the surfaces which are coming in contact? So these surfaces are very important to get this envelope of motion during the chewing and swallowing motion. So why is it important, envelope of motion? If you do not have anterior guidance, your mandible will not have a stop during the movement. It will come ahead of the anterior teeth, and then there will be a dislodgement of the TMJ. So anterior teeth plays a very important role during this envelope of motion. So vertical overlap, that is overbite and overjet, is very important. In the normal dentition, the tooth slides like this in the palatal area, and in attreated dentition, the distance traveled is very less. You see this arrow mark is longer here, the shorter arrow mark here. So the distance traveled here is very shorter. Why is it important? Right now, do an exercise. Get your teeth clenched in a normal way. There is a maximum intercuspation. Try to move your mandible forward and get in edge to edge position. Do you have open area in the posterior? Something called as Christensen phenomenon. Posteriors disocclude during the protrusive movement. That is what it should be after the restoration also. If the patient is having an attreated dentition, when the patient gets his tooth, anterior teeth edge to edge, there is attrition in the posterior. There is no gap for the ceramic restoration. That is why I'm telling you to check the occlusion before you go ahead with any kind of ceramic restoration in the posterior. In that case, you have to increase the vertical height, right? So I know you have been confused right now like this. What is this anterior and posterior? We just came for the ceramic restorations and we are learning in occlusion. I know this is very difficult to imagine because this is functional one, and I'm trying to make it, at least I will introduce you to this term so that you can go back and do a little bit of research or learn a little more on this. Okay, so that was about the protrusion. How is the lateral movement? That is left and right movements. We have two types. That is the group function occlusion, and one is the canine guided occlusion. Is it okay if I extend a little more than whatever is prescribed time for me? I think I have been left only 10 minutes, but I think I will go maybe at 10 or 15 minutes over the time if you're fine with it. So group function occlusion is nothing but the contact when the patient is getting the mandible to the right, that is the canine to canine are touching. You can do this right now. Touch your canines to canine tip. See how the posteriors are there. If you are having this kind of occlusion, you are having a group function. It means all the posterior teeth are touching to each other during the lateral movement. And that is the working side and the non-working side. So whichever side the mandible is moving, that is the working side, and whichever side the mandible is supporting, that's the non-working side. That's how the patient will be it will be look in the patient's mouth. Canine to canine are touching, all the posteriors are touching. That's the group function. If patient is having this, you have to give back the same during the replacement of the crown and bridge. When does it happen? When do you prefer this? When canine is compromised, that is attreated canine. The canine is attreated, so the vertical collapse is there. So when you have a canine crown you are giving, make sure the occlusion is set very properly. So when you check with this articulating paper marks, you should have a lateral marks like this equally. The dots are for the static occlusion. This lines for the dynamic occlusion. That was the reason I told you to grab a pen and paper and sit so that you will note down these terms and you will be repeatedly using in your practice, and then you are getting used to this. So next one is a canine guided. Get your canine mandible to the right and left and see, can touch the canine to canine, and then you will see only the canine is guiding your whole of the mandible and there is disocclusion in the posterior. Yes. How can only one tooth in the arch guide the entire lateral movement, you might say? You remember your bachelor days in the dental anatomy, we have been taught canines have the longest root. Canines are covered by dense cortical bone and have the long root. That means longer root means more pedial space. More pedial space, which means more mechanoreceptors. That means the mandible is guided and it is already controlled by the mechanoreceptors. That is a nerve control is there. And that's the reason this kind of occlusion is not a wrong what we are doing. You can replace the canine with this canine guided occlusion also. Okay. So canine replacement is very important. During the canine replacement is very important. So check the type of occlusion, lateral occlusion the patient is having. If not, you will have this kind of a mishap later. So with what you will check again, articulating papers, check the occlusion before the start. Two different kind of papers. One is a thick and one is a thin. And then when you see this mark here with the blue one, that is a thicker articulating paper, that's 100 microns or 80 or 65, you will see this occlusal area. And then you will see the red marking here. The red marking you see is the occlusal point. You will use this finishing burr and you will reduce this red marking and then little more of the blue mark. Again, you will check the occlusion. Again, if you feel that it is more dense or it is non-uniform in the rest of the tooth in the arch, you will follow the same protocol. So, okay. So I'll not stop here. Again, I'll use the ceramic polishing kit, polish the area, and you'll use a ceramic polishing paste to polish this. Or you get this ceramic crown, do this occlusal check and send back to the lab technician for doing the glaze of the ceramic. Either of this you can do. And after this, you have to check the occlusion. After checking the occlusion, you will take a PA radiograph or a bite wing radiograph and see how the fit of the crown is there. You see this open margin, this is not a good restoration. You see this is not a good restoration. This is not a good restoration. It should be something like this. Even though it's deep, there will be no open margin. Okay. This is a ceramic restoration. See, very nicely fitting. Okay. So dynamic occlusal points. Again, these are the ideal points which I already discussed. Check all these during the course of your treatment before the start. So anterior guidance is what I told you now. What's the posterior guidance? Imagine when you check the occlusion, what I said in the dynamic occlusion, only the dots has to be there. Dynamic occlusion is only dots. If you are seeing the lines in the dynamic occlusion, it means the mandible is sliding after the patient is opening and closing. This is the high point. You have to reduce this retruded contact position point here. Okay, this is called as RCP. This is very important. Okay, this might be your culprit for your breakage of the crown in the future after you cement. Okay, so this has to be removed. Then comes the muscles of mastication. Why is it important? Muscles of mastication are the ones which are holding our mandible in position, right? And then comes a special joint, that's a TMJ. If all this anterior and posterior guidance is not good, it will affect the muscles of mastication, and then again there will be an issue on the posterior area, that is a TMJ. So it's like a link chain holding the somatognathic system. This is called a somatognathic system. So once the link breaks like this, the whole system breaks. One or the other issue starts rising. Okay, so anterior guidance and posterior guidance are very important in your practice. Okay, more than that is a anterior guidance. And imagine this anterior guidance is lost. What will happen? Okay, the mandible will try to avoid that high point. Okay, you give a crown with a high point, mandible will try to avoid that high point area and try to bite in the other area. And there'll be alternate path of closure. There'll be no open and close of the patient as he was before. It is something different. This will continue, and then this will affect the crown which you have given. Imagine this is the crown which you have given with the high point. Over a period of time, patient is biting on that. There'll be forces and then stretching of the PDL, mobility will be there or attrition will be there. And with the course of time, it will go for extraction. Again, post extraction, what is happening? Migrations and or you have to replace this with the implant. That's the sequence of the if you leave behind a high point. Again, it will affect the muscles of mastication and the special joint, that is a TMJ, right? So this complex anatomy has to be incorporated, and you have to keep this in mind when giving the posterior. So how do you do this? You have to make sure you use a good articulator. Which articulator? Semi-adjustable articulator. Advise your lab technician to use, to not to use this kind of sectional articulators or this articulators or this articulators. No, you have to use semi-adjustable articulators, because the distance between this condyle and this condyle in the articulator is not the same as what it is there in the patient. You see, the distance between the incisal edge and the patient's condyle and the articulator is not the same. Okay, that's where the restorations fit very nicely in the articulator, I mean on the cast, but when you put in the patient's mouth, immediately there'll be a high point. So tell the lab technician to use a SM adjustable articulator, or you buy a one. I know it is a little bit costly, but you combine with your colleagues, 3 or 4 colleagues, join together and buy this articulator. Only this occlusal plates you buy around 3 or 4 pairs for yourself, so that this articulator is roaming around in between the patients, I mean, in between your colleagues, and for the patients, you can use your own mounting plates, right? You can do that for a start. So again, slowly you can invest on this. So if you are doing a full mouth case, not just semi-adjustable articulator, face bow transfer is must. Okay, so I teach all these face bow transfer and semi-adjustable articulator in the module of a course. We have an online and offline session for that. Will not go much deep because I cannot show you the demo of that. So see now this semigistral articulator, that's how the condyle is there. Okay, condyle and the patient and in the articulator. So how to find the centriculation and guide the patient into, say, centriculation during the full mouth rehabilitation case in the posterior. So always you have to take the patient's CR bite, that is a centric relation bite, whether it's a single crown or a quadrant crown or a full mouth crown or a collapsed bite. You have to take what the patient's MIP is there and then convert it into a centric relation bite. So again, PDL has mechanoreceptors. So if the tooth is lost, if the patient is having multiple missing areas, the bite is not stable. Okay, the patient bites into MIP because we have periodontal mechanoreceptors where the patient's PDL are guiding the patient's bite. Okay, so imagine the crown here. The red area is a crown. You have a high point. The high point is stimulated in the trigeminal neuralgia, trigeminal ganglion here, trigeminal ganglion. The red is the high point. So repeated doing this, the signals are getting we need to the signals are going to the trigeminal neuralgia, trigeminal nerve. I don't know why I'm saying neuralgia again and again. Trigeminal nerve ganglion. So what is happening with the high point? The nerve is getting excited. So what is happening? The nerve is getting excited. The nerve signals are going to the muscles of mastication, saying that, Mr. Patient, please do not bite on this area. Try to bite in the other areas because I'm getting the signals from here. So patient is biting in other areas than the his normal bite. So we need to trick our body. So we need to stop this feedback mechanism, which is going from the medial to the muscles to the brain. So how do you do that? With the deprogrammer. If the patient is not giving you a proper centric bite, do not go ahead with the preparation. This is what I mean to say. Because multiple missing teeth are there, and the patient is having a patient is having a previous dentition where the crown is there and with the high point, you cannot give the same, you cannot repeat the same bite on the patient after you giving the new restoration. So you have to use a deprogrammer. Why and how? Why I have told you right now? Because to block the signals, how? You have to give something called as anterior stop. If there is anterior stop like this here, the posterior will not be in occlusion, and hence the TMJ is not getting tense, and hence the muscles of mastication are very, very relaxed, and hence the the signal is not going. Understood the concept? So biting, getting a good centric bite is very important. Again, I'll just speeden up the process. This is a little more deep into the deprogrammers. I'll just show you the design, how it is done. It can be customizable like this. Okay, see the distance, only 1.5 millimeters. When the patient bites, you see a small dot like this. Only this area is the one patient will bite, so that there is posterior disocclusion like this. If the posterior disocclusion, patient is not biting on the tooth in the pack, the feedback mechanism is gone. If you get this kind of a bite when a patient is having the bite on the deprogrammer, no, you have to trim this and get this kind of a point bite. Only then the posteriors will be disoccluded very nicely. Okay, I'll not go much into detail how to fabricate this. This is a manipulation of the mandible chair side. It has to be done during this type of cases. This is a semi-adjustable articulator manipulation. This is all I teach in the hands-on sessions. Hopefully, we'll plan. I want to introduce you to all these steps so that you will have this into your mind when you're going ahead with a simple inlay or an onlay or a bridge or a crown in the posterior, right? So treatment planning is very important. Intra space is very important. Based on that, you will decide type of occlusion, that is your type of material and what thickness of material. Based on that, you will prepare the tooth. Okay, that is how the treatment planning goes. That's how the sequence goes. So what do I follow? If at all I need to increase the bite for the patient, I will follow this technique where I will raise 1 millimeter in the back. I will get 3 millimeters in the anterior. So I need to decide whether 1 millimeter space for the restoration back. You are giving a ceramic restoration and I need to raise the bite. If I raise 1 millimeter, I will get 3 millimeters in the anterior, right? Okay. So just take a photograph, keep it. This is a concept which we'll be learning more in the full mouth rehabilitation. So all cases require raise in the vertical dimension? No, because there is something called as passive eruption of the tooth. You might have been seen this kind of a situation. Long-term edentulous area, the supra eruption is there. Okay, so not always you will rise. You have to just reduce the tooth, do a gingivectomy bony, and then you can go with the same scheme of occlusion without going ahead with the increase in the bite. Okay, based on that, you will do a wax up and then full mouth rehabilitation. So we have seen from single crown, inlay, onlay, bridge, and then now we are reached doing the full mouth cases. So you need to keep all these into consideration. So again, make sure you have this cemented area clean. So take a radiograph, well and good. Tips to remember, what are the type cementation cements you will use? You will use only the self-adhesive cements or a resin cements for the cementation. If occlusion is not good, you will have these kind of a cracks. Okay, just to brush up, you'll have old restoration, remove, make sure all the old restoration is removed, protect the pulp, make impression, cementation, that's it, done. So before going ahead with the temporaries, you should be sure of two things. Which are two things? What vertical what vertical dimension you will keep, and is patient free from TMJ disorders. Okay, when giving the posteriors, make sure this back of the mind you have to just keep in. Okay, so again it is more deep. Again, if TMJ problems are there, again occlusal splints are very important, which I teach in the we teach in the basics of occlusion. We have a separate program for that. That's the basic of occlusion and the master level occlusion. So again, how do you maintain this? Never do ultrasonic scaling on the ceramic. No profi polishing, only hand scalers. Do a retraction if you feel that there is a calculus or a fleck of a cement is stuck inside the gingiva, in the sulcus. Ceramic polish is very important. Posteriors also, you have to give something called as hard splint to protect your occlusion in the ceramic. If not, they'll be chip off for sure. So again, this is a challenging situation. Solution is what I have discussed with you right now. So what you should do, again, the same I said last time: plan, plan, and plan. This is what you will need to do. And along with this, you will have to practice, practice, and more practice. There is no time for you to make mistakes. Learn all the mistakes from your colleagues, discuss with them. I have shared few. So there is no time for you to make mistakes. Learn from others' mistakes and you do a perfect job. Okay, so again, I want to share this video. I like this video very much. When you want to do something genuinely, the whole universe conspires for you. So as I said, again, let today be the start of something new, and get into the world of the ceramic, get into more complex situations, more complex restorations. Start with single ones, inlays, onlays. Start, do not fear giving posterior restorations with ceramic. I'm sure with the days of practice, you will go ahead and do a very good job. And I thank entire community of EDPA once again, all the participants here who have been here since past 2 hours now, spending your valuable time. Most importantly, President Dr. Meron, Treasurer Dr. Edis, all the office bearers of the CDPA, Dr. Esnid and Dr. Mendia, and all the EDPA community and the people again who are joined here, spending your valuable Sunday. And not to forget, again, I always appreciate my staff and my wife, who is a prosthodontist. Again, we share sharing this webinar with you is a cumulative effort of us doing something good to giving back to a dentistry. We love teaching whatever we know, and hopefully we have made any difference in your practice. And thank you once again. You can reach me out on these platforms anytime.